Now let's get to investigations, because the patient has come to you in the ER with epigastric pain, which is severe. Which investigations will you do? Okay, let's do the investigations. Serum lipase and serum amylase. Now, usually you want to use serum lipase. Why? Because serum amylase can also be produced in other parts of the body. I have a question. Which doctor can help me and tell me, apart from the pancreas, where else is serum amylase produced? Where else is serum amylase
The
produced?
GI. The
No, we're talking about the
Salivary
GI,
glands.
pancreas. Where else can you see serum? Where else can you see amylase?
the saliva.
Salivary glands.
Saliva,
In the mouth, in
exactly.
the mouth.
Saliva.
Alpha cell,
In the mouth.
pancreatic alpha cell, or
No, we are saying apart from the pancreas, okay? Where else? Yeah. So the doctors answered the mouth. And this is the reason. If you have somebody with cyanoadenitis, like, an infection of one of the ducts in the mouth, it can also lead to elevated amylase level. So there are other things which can confound that using amylase as the sole reason why you're going to diagnose the patient with acute pancreatitis. But then lipase is produced only by the pancreas. So the other reason why we also have to know this, especially because we are preparing for the MCQs, is also because serum lipase is more sensitive than serum amylase. Number 3, and please pay attention to this slide very well, because there's something here which will appear in your mock exam. Okay, so serum lipase levels rise earlier and it lasts longer compared to elevations of amylase. Serum lipase, aside it being very sensitive, it also rises earlier and lasts longer as compared to serum amylase. Now, another trick about this is because we said gallstones and alcohol are the two top, but gallstones is the topmost cause. Serum lipase is more sensitive compared with amylase in patients with pancreatitis. So serum lipase will rise earlier and last longer. It does not have any confounding secretory point apart from the pancreas. And if you have a client who has been taking alcohol for a long time, it is more likely that you're going to get a more sensitive test with serum lipase than serum amylase. So that's very important. Now, what's the next best step if you suspect pancreatitis but lipase levels are normal? So this can be a very important MCQ point you need to consider. Patient has come in with epigastric pain. Patient about 50 years old. You think this patient has pancreatitis, but then when you do serum lipase levels, it's normal. What should be your next best step? Your next best step should be to do a contrast-enhanced abdominal CT scan. You suspect acute pancreatitis so badly, but serum lipase is normal. What's the next best step? Do contrast-enhanced abdominal CT scan. Doctors,
Excuse me, Dr. Brunner.
Yes, please.
Suppose if a patient is there and there is no history of gallstones, or he doesn't know that, means there are gallstones and there is no history of alcohol intake. So in that case, we will proceed with abdominal ultrasound, or we have to go with the same kind of contrast-enhanced abdominal CT scan?
We'll come there. The only reason why you would do abdominal CT scan in a patient with suspected pancreatitis is when you suspect that the patient has a pancreatitis, but the lipase levels are normal. You will realize that the teaching is that every patient who has pancreatitis should get an abdominal ultrasound. Why? Because you'll be getting an abdominal ultrasound to look for gallstones. Because we said that gallstones are the topmost cause of pancreatitis. But when are we going to do contrast-enhanced abdominal CT scan? It is when we suspect that the patient has pancreatitis, but then the lipase levels are normal. Then in that situation, you want to request a contrast-enhanced abdominal CT scan.
Okay.
Yeah.
Thank you.
Good. Now, what other investigations should you do? Triglyceride level. Now, for those who are going to write next year, when should triglyceride levels be obtained? So it's not enough to know. It's not enough to know that these are the labs I'm going to request. But when is even the best time? When the patient has resumed normal eating since hypertriglyceridemia may be missed if the levels are obtained after prolonged fasting. You know that depending on the severity of the patient's presentation, the patient may be asked to fast. And so if the patient is fasting for quite a number of days and you may go to check, triglyceride levels, you may not see it. But then when the patient starts to eat normally, then you can know that you are getting an accurate test. And then you also want to do serum calcium levels. And you'll be asking yourself, why all this? Down the class, you realize that it is necessary to get the calcium levels. And one caveat about it, I can set a question and ask you, what will happen to the various, elements or the various components, calcium level? In patients with acute pancreatitis, calcium level will decrease. Calcium level will decrease. And then you need to also do some LFTs. With the LFT, if you do your liver function test, patient has epigastric pain, you don't know whether the patient has gallstones or not, and you see elevated ALT and AST. You see elevated ALT and AST. That is highly suggestive of gallstone or biliary pancreatitis. Let me say it again. Calcium levels will be decreased during acute pancreatitis attack. If you see a patient who comes in with pancreatitis and liver function test is abnormal, especially ALT or AST, then you want to start thinking about the fact that the pancreatitis is suggestive of a gallstone causing that pancreatitis. Now, remember that I was saying that if the patient is very young, you want to be very careful. If you have a patient who presents with acute pancreatitis and the patient is less than 35 years, or the patient has a family history of pancreatitis, then what you want to do is to do genetic testing. And some of the genetic testing is PRSS1, SPINK1, CFTR1, like CFTR, CTRC, CASR. Okay, these are, but the main thing I want you to take home from here is that if you have suspect a patient with acute pancreatitis and the patient is, say, 28, that is not normal. Then what are your next best steps? If I ask you that, also don't forget to do genetic testing as well. Genetic testing. And then you also want to do abdominal ultrasound. That was what one doctor asked. And it is because obtain an abdominal ultrasound in all patients with acute pancreatitis to evaluate for cholelithasis or choledocholithasis or signs of extrahepatic biliary tract obstruction. So if you are doing the ultrasound in a patient with acute pancreatitis, it's not because you are looking at the pancreas. No, rather you are trying to check the gallbladder to see if there are any stones there or if there is any extra biliary tract obstruction. That is the reason why we do abdominal ultrasound in patients with pancreatitis. So it's not because you want to evaluate the pancreas, rather you want to look for a stone.
Excuse me, Dr. Bernie.
Mm-hmm.
Yeah, are we still going to request for ultrasound if we already did the CT scan, the abdominal CT scan?
No. Because if you, the reason why we are doing the abdominal CT is to confirm pancreatitis in the situation where there's epigastric pain, but lipase level is normal. But then the teaching is that, look, it's still good to get an ultrasound. And it is, yes, you can get abdominal ultrasound even if the CT scan has been done. You can.
Okay, thank you.
Yeah. Okay, Dr. Cosmos, you're muted. Please unmute yourself.
Okay, yeah, Dr. Bruni, I want to confirm, we said that if there is increase in ALT and AST, that's the transaminases, that is suggestive of a gallstone cause.
Yes.
And the two commonest causes is gallstone and chronic alcoholism. Does
Yes.
that mean in chronic alcoholism, we won't have the increase in transaminases?
No, you will have an increase in transaminases, but we learned something the last time. Who can remind me? What is the ratio of AST to ALT that when you see, you realize that this is alcoholic liver disease? Who can?
It would be twice than ALT. AST would be double of ALT.
Exactly. So now, Dr. Cosmos, let me present it to you again. You have a patient, epigastric pain, and elevated ALT, elevated AST. What's the next thing you want to do? You want to do ALT to AST ratio.
Sure.
If I do ALT to AST ratio, and we call it the diuresis ratio. In fact, it's called a diuresis ratio. But at times, I don't want to get into those highfalutin stuff. If you do your diuresis ratio and it is more than 2:1, then boom, likely. And these things, it's not like it is definitive, likely an alcoholic cause. However, ALT and AST are elevated, patient has epigastric pain, but then you don't get that ratio, then likely gallstones. In fact, even with the one you're going to say it's alcoholic, like alcoholism, which may have caused it, in the long run, you're going to do an ultrasound anyway, right? So, and then even the patient's history can also tell you. If the patient denies drinking any alcohol whatsoever, then you are thinking more of gallstone. So, elevated liver enzymes in the context of pancreatitis can be as a result of alcoholic liver disease or gallstones. However, you want to check the ratio of ALT and AST. And if it falls in the range of alcoholic liver disease, then you want to go for that. And eventually, you want to still do an abdominal ultrasound anyway. Now, when you think about pancreatic cancer as a cause of acute pancreatitis, number one, the patient is more than 40 years. Number two, the patient started experiencing unexplained weight loss just before the attack. Number three, the patient has new onset diabetes. So you have a patient who is, say, 56 years old. Patient has been getting progressively losing weight. And then the patient was just diagnosed with diabetes. Start thinking about pancreatic cancer. And if there's a family history of pancreatic cancer in a first degree relative as well, that should also prompt you to start thinking about it. Now, if the etiology of pancreatitis is not clear, you don't know whether it is as a result of gallstone, you don't know whether it's as a result of alcohol, you don't know whether it's as a result of scorpion bite, triglyceridemia, you've got to do an endoscopic ultrasound to evaluate for pancreatic abnormalities or small tumors. Endoscopic ultrasound. Now, if the endoscopic ultrasound does not also reveal the cause, then you want to do magnetic resonance cholangiopancreatography. So let me take it again. Patient comes with epigastric pain, 56-year-old male. What am I going to do? As part of my evaluation, I'm going to request serum lipase, serum amylase. Which of the two am I going to go with? I'll go with serum lipase. Now, I'll then want to do my liver function test as well. If liver function test shows elevated ALT and AST, two diagnoses will still stick in my mind: alcoholic liver disease and gallstones. Then I do AST to ALT ratio. If that is more than 2:1, I'm thinking that alcoholism is what has caused this guy's pancreatitis. Okay. However, if I do all my investigations, I'm not really getting anything clear, then my next best step would be to do an endoscopic ultrasonography. Now, if the endoscopic ultrasonography comes back normal, then my next step is magnetic resonance cholangiopancreatography and secretin administration. So you realize that it is step by step by step. And that is why you need to know that concept. Now, somebody may ask that, but I thought endoscopic retrograde cholangiopancreatography rather is good. You realize that we are concerned about that because it has a lot of complications. And who should get endoscopic retrograde cholangiopancreatography proper? It is patients who have abnormal magnetic resonance cholangiopancreatography and endoscopic ultrasound findings. If those two are abnormal, then you want to do ERCP. As well, you do ERCP to diagnose a small tumor in the terminal bile duct or pancreatic duct in patients with suspected pancreatic neoplasm. And you also do ERCP to perform intraductal endoscopy in patients with the main duct intraductal papillary mucinous neoplasm. So these are the reasons why you want to do ERCP, or if the magnetic resonance cholangiopancreatography has failed, that's when you go in for ERCP. Now, what do you do if you have a client who has recurrent pancreatitis? Recurrent pancreatitis. what you need to do, your next best step should be endoscopic ultrasound. Recurrent pancreatitis, then that patient should get endoscopic ultrasound.